Okay, so hello everyone and welcome. My name is Chelsea Grover. I'm the Marketing Communications Coordinator for Attentive, and I'd like to take a moment to explain the process for today's presentation. First, I just want to mention that the webinar will be recorded and that we'll actually be making copies of that recording available to you next week. Okay, so on to today's webinar, Breaking Down MACRA. I want to share a bit of who we are with you. We've been in business as Attentive since 2003, but we've been NextGen users since 1997, EPM version 2.3. We specialize specifically in NextGen healthcare. We're good at getting data into, out of, around, and through NextGen. Basically, our goal in life is to make delighted clients by helping them get the absolute most out of their NextGen software investment. We're passionate about providing solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything NextGen, and we have two add-on productivity solutions for NextGen. One's called ChartGuard, and the other is Refund Manager. We're currently working on our next webinar, so stay tuned to our social media accounts and your inbox to hear announcements about when the next one is going to take place. Okay, so back to the webinar. We're going to take questions at the end, but you can type them in whenever they occur to you using the webinar control panel. And again, we'll answer them all in the order that they come, but just let us know when you think about them so they don't slip your mind. Okay, so I'd like to present our presenters for today, Lindsay Lanning, Cindy Kincaid, and Kathy Griesta. Lindsay is our healthcare compliance consultant, and Cindy is VP of Consulting Services, and both of them just did an amazing job at presenting at MGMA 2 weeks ago, so way to go, ladies, on that. And Kathy is a relationship manager, and she's an expert in this field, so we wanted to have her on as well. Okay, so Lindsay, I'm going to go ahead and pass it off to you. Feel free to get started whenever you're ready.
Great, thank you, Chelsea. Well, hi everyone, and thank you for joining us today for our webinar, Breaking Down MACRA. So here we find ourselves analyzing yet another industry-altering final rule, MACRA. And with this ever-evolving healthcare landscape, we wanted to take the time and help our provider partners better understand MACRA and the newly finalized quality payment program. So our objective is not to bore you to death with the amount of information that is in this presentation. Yes, we understand it's dry, but we've done our best to break this down into digestible pieces of information that we think are the most important. Our hope is that we leave you all with an understanding of the changes put forth by MACRA, specifically with what to expect and how to prepare for 2017. So stick with us throughout this presentation, and please feel free to come back to the slide deck as a resource for your own practice. All right, so in today's webinar, we're going to look at an overview of MACRA and the quality payment program, focusing on one of the two tracks offered through this new program, which is MIPS, where we will analyze each of the 4 performance categories found within MIPS, which are quality, resource use, clinical practice improvement activities, and advancing care information. We're then going to look at how MIPS is scored and get an idea of what type of payment adjustments providers can expect to see starting in 2019. We'll briefly look at APMs and their role in the quality payment program. And then we'll go ahead and end on ways you can prepare for MIPS in 2017 and ensure your success with this new program. Really, our primary focus today will be MIPS. We're going to go over APMs briefly, but CMS predicts that the vast majority of clinicians will be subject to MIPS in 2017. So that's what we really want to make sure you're all prepared for. So just a quick announcement before we begin so everyone's aware of a change for meaningful use reporting for this year, 2016. On November 1st, CMS released a final rule that includes a number of changes that affect the Medicare and Medicaid EHR incentive program. I included the changes on the slide, but just the one I wanted to highlight is that all returning participants in the EHR incentive programs can report on a 90-day EHR reporting period in 2016 and 2017. So this is great news for everyone on the call. It was announced a little late, but at least it's been finalized. Okay, so back to MACRA and MIPS and the quality payment program. First off, what I want everyone to do is take a deep breath and relax. I recognize this can be overwhelming, and understanding this new program may seem like a daunting task, but it doesn't have to be. Yes, the final rule was over 2,000 pages, but nothing has drastically changed. All 3 programs, Meaningful Use, PQRS, and Value Modifier, that we've been reporting on for years have kept their core structure and have basically just been rebranded. You're going to see the same requirements, reporting methods, and data submission methods stayed mostly the same. So while we go through this program, Make an effort to relate it to programs or measures that currently exist, and it will make it a lot easier to comprehend. And not only is this program very similar to existing ones, but believe it or not, it also decreases the reporting burden. It may not seem like it if this is your first time being exposed to the rule, but I promise it really is making reporting easier if you were previously doing all 3 reporting programs. All right, so I'm sure everyone's thinking enough with the pep talk, Lindsay. Let's just get started. So on April 27, 2016, the Department of Health and Human Services issued this proposed rule implementing key provisions of the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA, which is a piece of bipartisan legislation that replaced the flawed sustainable growth rate formula with a new approach to paying clinicians for the value and quality of care they provide. And this proposed rule is actually finalized on October 14th of 2016. So what I want to point out is the fact that this was a piece of bipartisan legislation. MACRA was actually supported by 93% of lawmakers, which is unheard of, and which also means it will likely not be repealed even with a new president in office. This idea was solidified yesterday on a call with Acting Administrator Andy Slavitt, when he also commented on the strong commitment in Washington to this legislation and that a new president would not change the future and implementation of this program. So it's sticking around. So if we look at Medicare payment prior to MACRA, it was this fee-for-service payment system where clinicians are paid based on volume of services, and each year Congress would pass a temporary Doc 6 bill to avert customer reimbursement. Actually, if MACRA didn't repeal the SGR in 2015, there would have been a 21% cut in Medicare payments to clinicians. So really what MACRA did was it replaced the SGR with a more predictable payment method that incentivizes value and also streamlined the 3 current quality reporting programs into one. So let's look at key changes this final rule put in place from the original proposed rule. These are things we will elaborate on throughout the presentation, but are important modifications to keep your eye out for. First off, the biggest and most beneficial change was 2017 being named a transition year, where providers have the option to pick their pace. This will allow providers to choose how they will participate in the first year to avoid a penalty. And we're going to go over each option they have a little bit later on. Next, the resource used or cost category was zeroed out, meaning it won't count towards the provider's MIPS score in 2017. The low volume threshold was adjusted so that a larger portion of providers would actually be excluded from MIPS reporting. And then we saw other changes, such as reduced measures for the ACI and CPIA categories, and lower reporting thresholds for that ACI category, expanded APM participation, and increased the floor for smaller practices. All right, so before we get into the details of the rule, I want to make sure we're all on the same page with the endless amount of new acronyms that have surfaced with this legislation. So some MACRA-nyms we should be familiar with include ACI, or Advancing Care Information. And this is basically just a new meaningful use program as one of the 4 performance categories under MIPS. We have APM, or Alternative Payment Model. These are basically just risk-based payment arrangements. CPIA, or Clinical Practice Improvement Activities. This is another new performance category under MIPS. MIPS, the Merit-Based Incentive Payment System. So this is that new meaningful use value-based modifier PQRS program. EC, that stands for a MIPS eligible clinician. This is really just a slight vocab change from what we're used to. We used to say eligible professional or an EP. We're now going to use EC, and that includes physicians, NPs, PAs, CNSs, or CRNAs. The QPP, or the Quality Payment Program, which is basically MACRA rebranded already. And then QP, or Qualified Participants, who are providers participating in an APM. So if we start by looking at the QPP, or the Quality Payment Program, it's basically a new unified framework for rewarding healthcare providers for giving better care, not just more care. And this framework has 2 paths, the Merit-Based Incentive Payment System, or MIPS, and the Advanced Alternative Payment Models, or APMs. So this new program, which will reform Medicare Part B payments for more than 600,000 clinicians, has been put in place to improve care across the entire healthcare delivery system. And its purpose is to lessen the burden on providers by replacing a patchwork system of Medicare reporting programs that we're used to with a flexible system that allows you to choose from two paths that both link quality to payments. So what now? We have these two paths to choose from, MIPS and APMs, but what are the differences and how do I know which one I should participate in? Well, those are some great questions. If we look at these two paths in terms of participation, CMS actually predicts the majority of practitioners will be subject to MIPS in 2017 versus that APM track. So this graphic displays the types of providers who will be subject to MIPS. So we have those who are not an APM. We have those who are in a non-advanced APM. And those that may be in an advanced APM but didn't qualify. And what I mean by that is some clinicians may be in an advanced APM, but they might not have enough payments or patients through that advanced APM to be a QP. So let's start by taking a look at MIPS since, again, most clinicians will initially participate in this program through this pathway. So what is MIPS? Well, the MIPS program combines existing quality reporting programs and rolls them into a single one. This single program contains 4 performance categories: quality, advancing care information, improvement activities, and cost. A clinician's or group practice performance in these 4 categories are what will determine your performance score and your payment rate. So the first performance period for MIPS starts January 1st, 2017 and goes through December 31st, 2017, meaning the first payment year for MIPS will be 2019. Really, what MIPS aims to do is to shift Medicare Part B clinicians to a performance-based payment system and provide clinicians with flexibility to choose the activities and measures that are most meaningful to their practice and their scope of work. So let's look at eligibility. Who's included? Again, I mentioned that minor vocabulary change, that it will no longer be eligible professionals or EPs. It will be now called eligible clinicians or ECs. And these ECs, again, are just those Medicare Part B eligible clinicians that participate in MIPS. So in years 1 and 2, these include physicians, PAs, NPs, CNSs, and CRNAs. Now, in year 3 and beyond, the Secretary may actually broaden eligible clinicians to include others such as physical or occupational therapists, pathologists, nurse midwives, dietitians, etc. So who's not included? Well, clinicians are excluded from MIPS if they fall into one of 3 buckets. Number 1 is that they're new to Medicare. In other words, they are newly enrolled clinicians who have never billed Medicare previously. Number 2, they bill less than $30,000 in Medicare allowed charges or furnish services to fewer than 100 Medicare beneficiaries a year. The earlier version of the rule actually set the exemption threshold for Medicare charges at $10,000 or less. So this adjustment was beneficial to providers. I also want to point out in this bucket that for groups where 75% of the clinicians fall under these thresholds, the entire group will be exempt from MIPS. And then lastly, ECs are excluded if they are significantly participating in an advanced APM. CMS does indicate that it will provide notice to clinicians and groups that fall into one of these 3 exceptions, either before 2017 or during 2017. So we can expect more details about the notification process in future guidance. We do also want to point out that MIPS does not apply to hospitals or facilities, nor does it apply to Medicaid. That means if you're a clinician who bills under both Medicare Part B and Medicaid, and you're above that low patient volume threshold, then you will have to dual report, or you're going to see penalties from Medicare. But good news, with these exclusions, CMS predicts that as many as 55% of clinicians will be excluded from any MIPS-related payment adjustment. Now, for those of us who will be included, MIPS allows Medicare clinicians to be paid for providing high quality, efficient care through success in 4 performance categories. And that's cost or resource use, which was formerly value modifier, quality, which was formerly the PQRS program, clinical practice improvement activities, which is actually brand new, and then advancing care information, which was formerly the meaningful use program. And performance in each of these categories is converted to a point system. And then those points are added together to get your MIPS composite score. Now, each of these performance categories is weighted differently towards your MIPS composite score. So if we look at this here, in 2017, physician practices will be evaluated on just 3 out of the 4 performance categories: quality, ACI, and improvement activities. Since cost has been weighted to 0 for that first transition year, each category will be weighted differently. Quality will actually account for the majority of the score. You can see at 60%. The ACI category will count for 25%, and improvement activities will count for that final 15%. So CMS won't count that cost measure in the 2017 MIPS score, but you can see over time the cost category will gradually become larger and the quality category will become smaller. So we're just going to go ahead and work our way through each of those 4 categories and provide you with a high-level overview of the reporting requirements, key changes, and just some important takeaways. So for the quality category within MIPS, it replaces the Physician Quality Reporting System, or PQRS. So this is where that program is going to be similar and have similar measures. So a provider must report 6 quality measures, including 1 outcome measure, or a high priority measure if none are available, or they can select a specialty measure set. And this is done for a minimum of 90 days. Providers can choose from over 300 individual measures or 30 specialty measure sets. And these measures will be selected annually through a call for measures process, and then a final list of them will be published by November 1st of each year. And then we did want to point out there are different requirements for group supporting through the CMS web interface or those who are on a MIPS APM, but we're not going to go into those details right now. So since the majority of us will be selecting 6 measures, including an outcome measure, to fulfill this category, CMS just recently launched a new website for the QPP, and it lists all the quality measures you have to choose from. You can filter these measures by specialty, and then you can actually click on them and expand them for details on what's being measured and what type of measure it is. So you can see on the left are just some examples of measures, and then on the right is one measure expanded. And then at the bottom of the screen, I also included a link to the website so you can look for measures that would best fit your practice. The next category is completely new, and it's called Clinical Practice Improvement Activities, or CPIA. So ECs actually select and complete improvement activities from an inventory of high and medium weighted activities. So high activities are worth 20 points, and medium are worth 10 points. And clinicians need to have 40 points in total to achieve full credit. So CMS did actually reduce this down from the final rule, or in the proposed rule it was 60 points, and the final rule now it's 40 points. So ECs would need to attest yes or no to completing up to 4 improvement activities for 90 days for full credit. So as of right now in year 1, all MIPS ECs or groups basically just have to designate a yes-no response on a CPIA inventory. However, CMS has said they will provide guidance on future reporting, but this year it's fairly easy. Now, there are preferential scoring opportunities for certain ECs and groups. For example, small practices or rural practices, non-patient facing ECs, they actually automatically receive half credit. So basically their requirement has been reduced and they only have to do 1 high-weighted activity or 2 medium-weighted activities. Now, accredited medical homes automatically receive full credit. In the final rule, CMS actually expanded their definition of how they will recognize a certified patient-centered medical home as well, to include one certified nationally at a state level, even locally or by private payers. And lastly, MIPS APMs automatically receive full credit, and other APMs receive at least half credit. Again, we also want to point out that ECs do have the opportunity to earn bonus points in this category if they use certified EHR technology when performing certain activities. So let's look at some activity examples. Again, this is from that same QPP website launched by CMS, where you can see all of the activities and choose ones that best fit your practice. So if we look at some examples, we have depression screening, diabetes screening, engagement of new Medicaid patients in follow-up, participation in CAPS, etc. So if you notice the ones that are actually circled in orange, these are considered high-weighted activities, and those are worth up to 20 points versus 10. So you would only have to choose 2 of those versus doing 4 medium-weighted ones. Again, this website is just a great resource to plan the best way to fulfill each of these categories for your practice. Moving on to the category cost or resource use, it replaces the value-based modifier, and it will actually start in 2018, since it's been weighted to 0 for this first year. CMS has stated that they will still provide feedback based on 2017 claims data. Even though it won't count towards your MIPS score, it'll be beneficial to see how you performed in this category. Also, all measures are calculated by CMS based on administrative claims collected for a full calendar year, which means no reporting is required. And the measures CMS is calculating are the total per capita cost for attributed beneficiaries and the Medicare spending per beneficiary, as well as some additional episode-based measures. Now on to our last, and I would say most complicated category, advancing care information. This category was built on the same infrastructure as the Medicare EHR incentive program, or meaningful use. Because when people don't like something, why not just call it a new name? This category does greatly reduce the requirements of meaningful use as we know it today, but you're going to see many of the same measures. First off, we have the required measures that must be fulfilled for 90 days, and their security risk analysis, e-prescribing, providing patient access, and health information exchange. The total number of required measures was reduced from 11 in the proposed rule to only 4 in the final rule. And all other measures would be optional for reporting. But if you do report on all 4 of the required measures, you would earn 50% of this category score. And reporting on the optional measures would actually allow you to earn a higher score. As well as for bonus credit, CMS will award bonus score for, again, those improvement activities that you utilize certified EHR technology, as well as for reporting to a public health or clinical data registry. And one thing to point out here is that there are actually 2 measure set options for reporting. The option you use to submit your data is based on your electronic health record addition. So option 1 is the advancing care information objectives and measures, and those are 15. Now option 2 is the 2017 advancing care information transition objectives and measures, and those only have 11. Most clinicians will be using option 2 to report on, since almost everyone is on the 2014 certification for their EHR system. And the 2015 certification isn't required until 2018. So that's the whole reason why they have these 2 measure set options. So I think the easiest way to break down this category and understand what's required is to look at how it's scored. You have the base score, which is 50 points, and then the performance score, which can be worth up to 90 points, in addition to the possibility of bonus points. Now you only need 100 points to receive full credit, but if you add those up, you'll see you get 155. So you have the ability to earn up to 55 points extra, which gives providers more flexibility on choosing what they want to report. It's no longer that all or nothing approach. So if we start by looking at the base score. First off, the base score is a set of required measures, and failure by an EC to meet any of the base score requirements will result in a 0. not only for the base score, but also for the entire ACI category. Don't worry, base score thresholds are either going to be one patient or a yes/no attestation. So very easy to accomplish. For example, if we look at the ERX measure, it states at least one permissible prescription written by an EC is queried for a drug formulary and transmitted electronically using CERT. So again, it's just that one prescription. Or patient access. It's just one patient seen by a clinician are provided timely access. And lastly, if we look at this graphic, you can see what I mean about having two measure sets to report on. It just depends on your EHR certification criteria, which again, for almost everyone on this call is going to be 2014. So we would report on the 2017 ACI transition objectives, which only has those 4 required objectives in this base score. Next, we have the performance score, which are the measures you have the flexibility to choose to report on for additional points. So there are 7 performance measures in the 2017 version, and that actually includes 2 from the base score. So each measure is worth 10 points, besides the 2 from the base score, which are worth 20. You can see those are patient access and HIE. So the EC has 90 total points possible for the performance score. How this works is, let's say your provider achieves 90% on any one given measure. That means they would earn 9 points. Or let's say if they score an 85% on medication reconciliation, you would round up and they would receive 9 points for that measure. So you would add your performance on each measure up and put that out of 90, and that would be your performance score added to your base score of 50 for a total possible of 140 points when you only require 100. Now, you might be asking, wait a minute, the slide says 155, not 140. Where are those extra 15 points factoring in? And those come in at the end as bonus points. So clinicians can earn up to 5% or 5 points for reporting to one or more additional public health or clinical data registry beyond immunization reporting. Providers can also earn up to 10% or 10 points in the performance score for reporting on those designated improvement activities using certified EHR technology. So just to recap, you have quality, where you report on 6 measures, including 1 outcome measure, cost, which will not count towards your composite score in 2017, ACI, which is the measures and scoring we just went over with the base and performance scores, and then improvement activities, where ECs can report on up to 4 activities. Keep in mind all of these are weighted differently and contribute to your MIPS composite score. So now that we know the requirements for each category, let's look at how participants will actually submit data. So we can see here all of our submission options for all 4 categories. 2 things I want to point out are that 1, clinicians can report as either an individual or a group across all 4 categories. And number 2, most of these submission options are the same as prior programs. So if you send MIPS data in as an individual, your payment adjustment will be based on your performance. And an individual in this case is defined as a single NPI tied to a single tax ID number, or TIN. So you'll send your individual data in for each of the MIPS categories through, you can see the options here in EHR, registry, qualified clinical data registry, and you can also do it through your routine Medicare claims process. Now if you send your MIPS data in with a group, the group will get 1 payment adjustment based on the group's performance. And a group is defined under MIPS as a set of clinicians sharing a common tax ID number. And your group will send in this group level data for each of the MIPS categories through a CMS web interface, an EHR, registry, or a QCDR. So this is just another way to look at which categories support data submission options available to an EC. You can see clinicians and groups have many options for reporting MIPS data. And we know eligible clinicians can report as either the group or individual, but they must do so across all 4 categories. However, they may utilize different reporting mechanisms to submit data in different MIPS categories. So, for instance, a group may submit quality measure information via claims and then attest to ACI and improvement activities. So once you decide you're reporting as a group or individual, you have to report that way across all 4 categories. You can't report group for quality and individual for ACI. But what you can do is report as a group across all categories and maybe choose to submit registry for quality and then EHR for ACI and a test for CPIA. So this can be a bit confusing, and it is a change from the programs we have in place now, but should ultimately work for an EC's benefit. And that's not the only benefit we're seeing with this new program. For 2017, providers will have this pick your pace option. And I mentioned this earlier as a very big change in the final rule to help clinicians with this program transition. So we understand this program is set to begin on January 1st, but CMS has established special policies for the first year of this program, which they're referring to as a transition year. And during this year, physicians are allowed to pick their pace of participation for this first performance period. So clinicians will have 3 flexible options to submit data to MIPS, and a 4th option to join an advanced APM to make sure you don't receive a negative payment adjustment in 2019. So if we look at these options, let's start with the full option and work our way backwards. So option 1, clinicians can choose to report MIPS for a full 90-day period, or ideally a full year, and maximize your chances to qualify for a positive adjustment. Also, we want to point out clinicians who are exceptional performers in MIPS are actually eligible for an additional positive adjustment for each year for the first 6 years of the program. And that's actually funded from an entirely different organization in place. Option 2, clinicians can choose to report MIPS for a full 90-day period at a minimum and report more than 1 quality measure, more than 1 improvement activity, or more than the required measures in the advancing care information category in order to avoid negative MIPS payment adjustment. And you can also see possibly a small positive MIPS payment adjustment. Or clinicians can choose to report 1 measure in the quality performance category, or just 1 activity in the improvement activities, or just the required measures in the advancing care information category, just to avoid a negative MIPS payment adjustment. However, if ECs choose to not report on anything, not even 1 measure or 1 activity, they will receive the full negative 4% adjustment. So, quick summary. For 2017, clinicians can just opt not to report any data, and they're going to automatically see that 4% penalty. But if you report just 1 quality measure, or just 1 improvement activity, or those 4 ACI base measures, you're going to see a 0% adjustment, or if you're going to be in the clear, you'll be neutral. Now, if you choose to report on just more than 1 quality measure or more than 1 improvement activity, you actually have the possibility, you're not only going to see a 0% adjustment, you have the possibility to see a small positive adjustment. And then lastly, you can report all the MIPS data for 90 days and actually see a larger positive adjustment. So this is a tiered approach to reporting where you can decide at which level you want to participate. But CMS is making it fairly easy to, at the very least, avoid a penalty in this first year. So now that we know what we have to do to report and how we will report, let's look at an overview of the MIPS program scoring. So we can look at these 6 steps to determining a clinician's payment adjustment. First, we have data submission by an EC, and that's done as either an individual or a group. Then you have category scoring, so going through each of those 4 categories, evaluating performance, and converting those measures or activities into points. Which brings us to step 3, calculating the composite performance score based on category weights. Then CMS is going to compare your composite performance score with the threshold that's already been established. Then it will determine your payment adjustment. And then finally, in 2019, will actually apply your payment adjustment. So we can see through the steps, a key to how you perform is that composite performance score. and that performance threshold and what you're compared to. So for the MIPS performance threshold in 2017, it's actually going to be 3 points. Yes, you heard correctly. ECs and groups will only need a performance score of 3 points to avoid a payment penalty in 2019. CMS actually estimates more than 90% of MIPS ECs will receive a bonus or at least avoid a penalty in this transition year because of this reduced threshold. So why 3 points, you might be asking? Well, if you report one activity or one quality measure, it's worth 3 points. Even if you don't have enough data, if you report anything, it will be worth 3 points and you will avoid a negative adjustment. Now, for those of you looking to use this transition year to get ahead and earn an incentive, ECs who achieve a final performance score of 70 or higher will be eligible for a portion of the exceptional performance adjustment, which is again funded from a separate incentive pool of $500 million. So you get to pick your pace for this program. If you're ready, you can begin January 1st, 2017 and start collecting your data. If you're not ready on the 1st, you can choose to start anytime between January 1st and October 2nd, 2017. However, whenever you choose to start, you'll need to send in your performance data by March 31st, 2018. Medicare will then give you feedback on your performance, and that first payment adjustment will go into effect on January 1st, 2019. Specifically, CMS will notify clinicians and groups of their MIPS performance, their MIPS composite score, and any respective penalty or bonus by July 1st, 2018. So practices will then have 60 days to contest any errors, and then again, payments are going to start being adjusted in 2019. And you can see the payment adjustments will continue to grow each year, reaching 9% in 2022. So if we look at the projected MIPS adjustments for 2017, we can see as a result of that pick your pace option, combined with the MIPS budget neutral design, CMS anticipates a max incentive of less than 1%, which is much lower than the 4% that's currently allowed under the statute. So you can see if providers submit no data, they're going to automatically get that 4% adjustment. But the higher their score, the greater chance of a positive adjustment. Because the losers have to pay the winners, so to speak, CMS is predicting the positive adjustments will be relatively small due to the ease of avoiding a penalty with, again, this pick your pace option. All right, so if there are 2 slides out of this entire presentation you walk away with, we want it to be these next 2. These are your need-to-know facts for the first year of MIPS. And first is how to avoid a negative adjustment in 2019. Again, because the MIPS performance threshold is set at 3 points, physician practices that submit a minimal amount of data will avoid a penalty. Specifically, practices may report one of the following options just to avoid a MIPS penalty: 1 quality measure, or 1 improvement activity, or the ACI base measures. However, we strongly recommend providers to report or attest to more than 1 measure as an insurance policy in case you experience any data submission issues or inaccuracies. Because failure to report even 1 measure will result in that negative 4% penalty to Medicare payments. So why not submit a few just to ensure you're not going to see a negative adjustment? Keep in mind, you can also use this transition year as the opportunity to learn how to participate in the program in a relatively risk-free environment. And I think that should significantly factor into your decision on how you're going to participate in 2017. And lastly, how to earn a positive adjustment in 2019. To maximize the MIPS score and potentially earn a bonus, practices should take the following actions. For the quality category, you want to report performance data spanning at least 90 days on up to 6 quality measures. Each measure is compared to a national benchmark, and you can earn up to 10 points per measure. But let's say you report a measure with a low performance rate, or that you don't satisfy benchmarking data or the data completeness requirement, you're still going to receive a score of 3 points. just for submitting data. The ACI category, report or attest to meeting 4 base measures. These measures are the all or nothing ones, and they're actually worth half your score. And then you can also report performance on 7 additional measures to earn the additional points. And lastly, improvement activities. Report or attest to completing up to 4 improvement activities for 90 days. And then groups, again, in PCMHs or certain medical homes may automatically receive full credit, or 15 points. And also we wanted to point out, practices can earn bonus points or bonus credit for completing EHR-related improvement activities or submitting data to an extra public health registry. All right, that wraps up our review of MIPS. So we're going to go ahead and move on to a very brief overview of alternative payment models, and I'm going to go ahead and turn it over to Cindy Kincaid for this section. Cindy?
All right, everyone, thank you. And as Lindsay said, we're going to try to be brief on this so that we can allow time for all of the slides and questions at the end, given that everyone, or the vast majority of people, will be using the MIPS program this year, at least in 2017. So let's first of all talk about alternative payment models. What are they? I'm sure if you are participating in them, you're going to understand them, but we're going to briefly give a description. An alternative payment model is a payment approach that provides added incentives to clinicians to provide high quality and cost-efficient care, and I think everyone is doing that. However, in order to be eligible for some of the incentive payments, the advanced APMs are a requirement, and this is a subset that enables clinicians to earn greater rewards for taking on some additional risk related to their patient outcomes. So what is an advanced EPM? Well, first of all, they have to meet 3 criterion, and the first one is that it requires that at least 50% of the clinicians in each APM entity are using certified EHR technology to document and communicate clinical care information with its patients and other healthcare professionals. In addition, there's a shared savings program that requires the clinicians to report at the group tax ID level according to MIPS rules as opposed to individual. It also provides for payment for covered professional services based on quality measures comparable to the measures under the MIPS performance category, and at least one of these measures must be an outcomes measure if an appropriate outcome measure is available on the MIPS measure list. And finally, it requires that you bear more than a nominal financial risk for monetary losses or be a medical home model expanded under the Center for Medicare and Medicaid Innovation. And what does that expanded financial risk mean? Well, a brief description is, well, you must have the ability to have at least 8% of the average estimated total Medicare Parts A and B revenue of participating APM entities, or 3% of the expected expenditures for which an APM entity is responsible under the APM. So that's a pretty complicated calculation, and we're not going to get into how that's calculated today. However, as you can see, it does require some financial risk on the part, and there is a minimum level. Let's take a look at the advanced models for the year 2017. These include comprehensive end-stage renal disease care model, comprehensive primary care plus CPC, the Medicare Shared Savings Programs Track 2 and 3, and the next generation ACO model. Now, while the application cycles for participation in these models have closed, CMS does intend to expand this in 2018 and also plans to reopen the application cycles for CPC Plus and the next generation ACO model for also for 2018. These would include adding ACO Track 1, new voluntary bundled payment model, and advancing cardiac care coordination through episode payment models. So what are the incentives for APMs? Why would you consider this? Well, advanced APMs qualify certain participants for inclusion or exclusion from the MIPS reporting. You wouldn't have to do MIPS reporting in this. And you can get a 5% bonus payment, and you're eligible for higher fee schedule updates beginning in 2026. However, only qualified APM participants, QPs, and advanced APMs will be excluded from MIPS in 2017 and receive the 5% lump sum bonus. So how are you qualified? Well, clinicians must have at least 25% of their Medicare Part B payments or 20% of their Medicare patient population flow through the advanced APM, one of these two options. And as Lindsay mentioned in an earlier slide, you have an option to be a partial QP. And what that means is that you could be a designated partial QP if you have at least 20% of your Medicare Part B payments or 10% of your Medicare patient population flow moving through the advanced APM. Now, if you are a partial QP, you would be able to forego participation in MIPS, but you would not be eligible for the 5% lump sum bonus payment. And how is this determined? CMS will make the QP determinations 3 times during 2017, period March 31st, June 30th, and August 31st. And reaching the QP threshold at any one of these 3 determinations will result in a status for the eligible clinicians in the advanced APM entity, since it is a 90-day reporting. So eligible clinicians will be notified of their QP status after each determination is completed, and as you can see in the graphic, that would be at point D. Now, again, you don't have to necessarily, you can be part of a non-advanced APM and not be qualified as an eligible QP or a partial QP. And in that particular case, these clinicians and groups will receive full credit in the improvement activities categories of MIPS automatically. And if applicable, you will also be able to report quality measures through the APM and be evaluated on ACI Performance collectively as well. So you do have some incentives, even if you are part of an APM, but you don't make the qualifications as a QP or partial QP. So we've looked really quickly at the advanced APMs and non-advanced APMs, and now we want to talk a little bit about preparing for success. And I'm going to turn this over to Kathy, and she will take you through how to prepare for success regardless of which models you're choosing in.
Hello, everybody. So how do we prepare for success? We want to ask some questions. First off, on quality, what are some of our preparation questions? Did you successfully report PQRS? How are you reporting? What measures are you reporting on? And do they match any offered under the MIPS quality category? Next, what is our resource use? What questions can we ask ourselves? How did you do on your value modifier? Do you know what value modifier is? Are you seeing a payment adjustment? Do you know if you are seeing a payment adjustment? Do you know how to review your QRURs, which are your quality and resource reports? You can find your quality resource reports on the portal.cms.gov. Next, your ACI, your advanced care information preparation questions. Did you successfully report meaningful use in 2015 or previous years? Did you take advantage of the hardship in 2015 rhythm a test? Have you recently ran your HQM reports? And after running your HQM reports, would you pass MIPS ACI category today? Preparation questions for your CPIA, which is your clinical practice improvement activities. These are new, as Lindsay pointed out. Have you looked at the activities available to report on? Are you currently participating in any activities listed right now? Are you a PCMH? Are you considered a small practice under MACRA? Some miscellaneous important points that we want to point out to you is the Medicaid EHR incentive program remains separate, and it's still in play. Submission methods remain the same. There's a 90-day reporting period in 2017 and 2018 to help prepare to support the certified EHR upgrades that will be necessary. Starting January 1, 2017, eligible clinicians will have 3 additional statements they must attest to. Eligible clinicians did not limit or restrict the capability or interoperability of certified EHR technology. EC's implemented technology, standards, policies, practices, and agreements to allow for timely, secure, and trusted bidirectional exchange of electronic health information with other providers. ECs responded in good faith and in timely manner to requests to retrieve or exchange electronic health information And hardship exceptions will remain the same as existing exceptions in the 2016 Meaningful Use Program. The hardship is only related to the ACI category, and if granted, the ACI category is weighted at 0% for MIPS final score, and the 25% is then shifted to the quality category. By failing to prepare, you are preparing to fail. I think we can all agree this new program requires a lot of preparation. Cindy, do you agree?
Absolutely. And this is how we can help you. You can let us help by assessing your current readiness. We can provide recommendations to your group. We can assist you with implementation of new processes and procedures in order to succeed. In addition, a few of the other things that we're going to be talking about, as Chelsea mentioned earlier, we are working on our next webinars. One of the things you're going to have to understand are your upgrade processes within the applications that you're using. Primarily, everybody on the call is with NextGen. We're going to be putting out a webinar on the NextGen roadmap and how it applies with different upgrades and different things you will need to take in order to achieve these things in 2017. You can also, in addition to watching for our webinars, visit us at itentive.com. You can sign up for our blog. All of you obviously are aware of our webinars. You're on it today. You can consider our 3-day fixed-price on-site consultations for clinical workflow, revenue cycle, and front office procedures, and then our technology and performance reviews, including some valuable HIPAA and high-tech audits that are applicable for security. And then you can test drive the 2 products that Chelsea mentioned at the beginning of the presentation. So for now, we're going to turn it over to questions, and I think we have a few out there. So Chelsea, I'm going to hand it over to you to move the questions forward. Thank you, everybody.
Thank you, Cindy, and thanks, Lindsay and Kathy. That was so much information. I'm still processing it. But it does look like we have some questions coming in, so as a reminder, you can type them in the questions area of the webinar control panel, and we're just going to get to them in the order that they came, with the exception of one. We've had a lot of people asking this. Will we be sending out copies of the slides? Yes, we will be making copies of the slides as well as a recording of this webinar, and we'll be emailing that out next week. So keep your eyes out for that. Sometimes it goes into spam filters, so if you don't see it, check there, or feel free to reach out to any of the people that you see on the screen, and we'd all be happy to give it to you that way. Okay, so first question. If we choose to report as individual versus a group, and we have providers that have less than 30K Medicare charges, can they opt to participate in MIPS, or are they automatically excluded? Hear me still?
First one I'm going to send to Lindsay. If we choose to report as individuals versus a group, and we have providers that have less than 30K Medicare charges, can they opt to participate in MIPS, or are they automatically excluded?
Thanks, Cindy. Sorry about that. I lost my internet for a moment there.
All right, I've thrown the first one out, so Lindsay, can you grab that one?
No problem. I can grab that. So if they're billing under $30,000 in Medicare charges, you don't have to participate in MIPS, but if you want to, you are welcome to, especially in this first year, this transition year. We're seeing a lot of providers and practices actually opt in to participate just for the possibility of a positive incentive, since, again, this is a relatively risk-free environment to try and do it. So if you're billing under $30,000, you're not automatically excluded, and you can choose to participate. You just don't have to.
Thanks, Lindsay. Okay, next question. Is the list of measurables/sets available, and if so, where can we find it? Lindsay?
Yep, so the obvious first resource I'm going to send you to is the final rule. Control F is your friend with that. They have actually the different tables located at the end of the rule. That's going to be your best resource, but I actually prefer, it's the QPP website, and I have a link on 2 of the slides in this presentation. It's the Quality Payment Program website CMS just launched less than a month ago, and they actually go by category and list all the measures, and you can actually add them to a cart and save them down for your practice. So I would recommend going to that website or the final rule and looking at those tables.
Thanks, Lindsay. Next question. Is there an anticipated date as to when our providers will receive notice if they are excluded?
All right, I think we're losing Chelsea again. We got some internet issues today, so I'm going to grab. close it out. Is there anticipated dates as to when our providers will receive notice if they are excluded?
I can grab that one. So through CMS's PowerPoint, they actually addressed this, and they just said they're hoping it'll be before 2017, but most likely it will be during the year of 2017. So no one knows a for sure answer on that, but they have addressed it, and we are hoping that it's going to be at least earlier in the year in 2017. We're going to look for further guidance on that from CMS.
All right, those are the questions we have so far. Are there any others? We're going to give it a few minutes, and while we're doing that, I personally want to thank Lindsay. She did the bulk of the research, in fact, pretty much all of the research on this, and I just added some commentary and things to it. This has been some really strong information to weed through, and it's a lot of information, and I just appreciate all the effort that Lindsay put into this and pulling this together and bringing it to a format that I think is at least understandable while it's still really a lot of data. And if you come up with any questions or you're thinking of anything, I don't see anything new coming in, but if you do, feel free to email us or reach out to us, and obviously the slide presentation will be there, and we will be putting out more webinars as it comes through, particularly as it relates to the upgrades that are going to be required to move forward in this environment. As you know, NextGen has come out with quite a few, and also have plans for quite a few for any of you that were at the user group meeting, and we're going to be trying to facilitate some of that data over the course of the next couple of months. If we don't have any additional webinars, or you don't, I hope you have a wonderful Thanksgiving and a happy holiday season, and we look forward to seeing you on our next webinars or assisting you in any way that we possibly can. I think, is there anyone else that wanted to add anything before we close the webinar today?
Cindy, it looks like we got one more question in. Which
Okay.
track will FQHCs follow?
I can grab that one as well. So FQHCs are a little bit different. What you really want to focus on with FQHCs is, first off, if you're going to fall under that low volume patient threshold. So they actually loosened up the requirement in the proposed rule, which I'm not sure if you noticed, they adjusted it. It was you had to bill under $10,000 in Medicare Part B charges and see less than 100 patients. Now that's changed. You would bill under $30,000 in Medicare charges or see under 100 patients. So what I've been noticing after talking to a lot of people at FQHCs is they didn't realize the adjustment to that low volume threshold, and they're basically, most of them are being excluded from the MIPS adjustments. So I would say check that first. Otherwise, if you do fall above that threshold, you would be following MIPS.
Great. Well, it looks like that's all that we have. So thank you, everybody. If you have questions that we didn't answer, feel free to email them up to us, to the people up here. And thanks for your time today. And ladies, thank you for all the hard work that you did on this presentation. And have a great day and happy Thanksgiving.
Goodbye, everybody.
Bye, everyone. Thank you.